I'm the Executive Manager of ICAN. I want to welcome you to series number 11 that we are starting today. So we are so grateful that Africa CDC, WHO and Africa Union has helped us to be able
Recording
to
in progress.
I just want to apologize up front to say that today, unfortunately, there won't be any interpretation, but that will happen from next week. We had a small glitch and we've sorted that out. So next week we'll have the Portuguese and Arabic interpretation as well. Another reminder, tomorrow there will be the French version that's happening the same time as we've done in the last year. So please, all the French people can join for tomorrow as well. Just some housekeeping rules. If you can all please keep your videos off, keep yourself muted. If you do have any questions, please put it in the post of the Q&A box. It's easier for us to respond. It's difficult to answer questions in the chat box. Just another reminder, this is a series that runs over 6 weeks. You have to attend at least 4 out of the 6 weeks, and you have to stay on for at least an hour before we are able to send you a certificate. You also need to register and make sure that we've got all your right details so that at the end of this series, Susan will be able to send out the certificates as well. The presentations will be made available at the end of this series on our website, which you will be able to access there as well. So without further ado, I just want to also say thank you for our panelists, for Africa CDC, for ICAN, for the WHO, for our partners that is joining us to help assist us with this. So I'm going to move forward with the first presentation, and I want to welcome Betty or Bethlehem Tebetu from Africa CDC, and she's going to give us an overview of the status of the COVID. So over to you, Betty.
Thank you very much. And if I can share my screen. Good afternoon, all. My name is Bethlehem Tebetu. I am an EP analyst in Africa CDC, and I will take you through the COVID-19 situation update on the continent. Starting with the global situation, to the left of the slide, there is an epi curve showing the number of new COVID-19 cases reported by the 6 WHO regions. The number of new cases reported globally has started to decline. Last week, more than 21 million new cases were reported globally, which is a 10% decrease in the number of new cases reported. As of yesterday, over 394 million cases and 5.7 million deaths have been reported globally, with a case fatality rate of 1.4%. Looking at the continental situation, the map on the left shows the cumulative cases being reported from each member states. Majority of the member states are reporting cases between 1 to 100,000, as shown on the map on the light pink color. The epi curve on the right shows the new cases reported by day from the beginning of the pandemic till yesterday. We observed a downward trend in the new cases being reported for the past week, as shown by the 7-day moving average. 9 million cases have been reported, with over 242,000 deaths, resulting in case fatality rate of 2.2%. There have been more than 10 million recoveries, making up 89% of the reported cases. Taking a look at the trends over the past month for the continent, this chart is showing the number of new COVID-19 cases reported by week for the past 4 weeks. And over the past 4 weeks, On average, the number of new cases have decreased by 18% each week. This slide shows the trend in new cases over the past month for the 5 AU regions. Each panel on the slide is showing the number of new COVID-19 cases reported over the past 4 weeks in the 5 regions. The red in the black line shows the trend in the percentage change of new COVID-19 cases by week. By region, over the past 4 weeks, there has been an average of 43% decrease in the central region, 31% decrease in the eastern region, 14% increase in the northern region, 30% decrease in the southern region, and 49% decrease in the western region. The map on this slide is showing the member states that are experiencing a sustained upward trend in the number of new cases being reported for the last 2 weeks. As shown on the map on the right side, Egypt and Libya are currently experiencing a sustained upward trend in reporting also the presence of the Omicron variant. This slide is showing the distribution of new COVID-19 cases reported per 1 million population per day across the continent. In the past epidemiological week, 28 countries have reported less than 5 new cases per million population per day, while 5 countries reported 80 or more new cases per million population per day. And this week, we do not have information for 4 member states. The daily COVID-19 incidence continues to decrease across the continent, with the majority of the member states reported a decrease in the incidence compared with the previous week. This slide is showing the AU member states that are reporting Omicron variant. This week, 1 additional member state, that is Central African Republic, have reported the presence of the Omicron variant. There are a total of 40 member states that have reported the presence of Omicron variant in the continent. This chart is showing the number of new COVID-19 deaths reported by week for the past 4 weeks. The red line shows the trend in the percentage change of new COVID-19 deaths by week in Africa. Over the past 4 weeks, there has been an average of 3% decrease in the number of new deaths being reported each week on the continent. The chart on this panel is showing the number of new COVID-19 deaths reported over the past 4 weeks in the 5 AU regions. The red and the black line shows the trend over the percentage change of new COVID-19 deaths by week. By region, over the past 4 weeks, there has been an average of 13% decrease in the central region, 10% increase in the eastern region, 26% increase in the northern region, 14% decrease in the southern region, and 13% decrease in the western region. This slide is showing the COVID-19 case fatality rate by AU member states, classified into 4 categories. 31 member states are reporting a higher CFR than the global CFR of 1.4%, and 11 member states have a CFR that is less than 1%, and 3 member states have a case fatality rate that is greater than 5%, and these countries are Egypt, Sudan, and Somalia. The change observed in the CFR in comparison to last week was a decrease in 9 member states, and these are Chad, Mauritius, Somalia, Sudan, Egypt, Libya, Tunisia, Lesotho, and Guinea-Bissau. This slide shows the summary of COVID-19 testing on the continent. Cumulatively, over 96.4 million tests have been conducted, with a test per case ratio of 8.8 and positivity rate of 11.4% respectively. In the past week, more than 1 million new tests were conducted, which is a 14% decrease in the number of tests conducted in week 4 compared with the previous week. Looking at the test positivity by EU member states in the past epidemiological week, 20 member states have a test positivity that is less than 3%, while 6 countries have a test positivity that is 12% and above. The test positivity decreased in 31 member states last week, and we do not have a laboratory information for 18 countries this week. The test positivity continues to decrease across the continent, and in the past week, there was a 16% decrease in the positivity rate compared with the previous week. Thank you for attention. Over to you.
Thank you very much. This was wonderful to see what is happening and great to see so many decreasing in cases. So thank you very much, and it was brilliant what you've done for us. I want to introduce the next speaker. I want to introduce Prof. Valerie Robertson. She is co-chair of the IPC pillar in Zimbabwe COVID-19 response. She's also the honorary secretary of the ICAN, and she's also working with ICAS, which is the Infection Control Society in Zimbabwe. Prof. Val will take us through the country experience from Zimbabwe. Over to you, Prof. Val.
Thank you, Anna. And thank you very much for that last presentation. It was really excellent overview. Do I need to share my slides, or will you?
If you can share, otherwise we can share for you. If you've got a problem, you can just let us know.
Okay. Can you see that?
Yes, just go to your slideshow mode.
Thank you, and good afternoon, good morning, everyone. Thank you for the opportunity to share a small part of our experience. In the time available, it's not possible to talk about the whole Zimbabwean experience, and I'm not really qualified to do so. So what I do want to do, just give you a snapshot of the epidemiology in Zimbabwe, look into the background of our national COVID-19 response, but specifically focus down on the National Infection Prevention and Control pillar and look at particularly IPC pillar training activities and the interventions that we feel have been helpful. We can't prove that they've worked, but we have quite a bit of experience now of what we feel does help strengthen particularly our infection prevention and control programs. So this is our snapshot of our statistics in Zimbabwe. So we're a small country, so number of cases, just over 200,000 with just over 5,000 deaths, and our case fatality rate is 2.3. I've included the healthcare worker statistics because for all of us, that's of enormous concern, and particularly in our country, that overall over 11,000 healthcare workers have been infected during the course of the pandemic, and there are 69 deaths. But vaccine coverage goes up and down. So we're over 4 million people have received their first dose, and over 3 million their second. We've recently started issuing third doses, particularly for frontline workers and for the over 60s. And you can see from our epi curve that our numbers have come down quite dramatically, but were very much higher than the other waves, so up to 6,000 cases per day. So quite dramatic. We have, as you heard earlier, we're one of those countries that have identified the Omicron variant, but it was only a small number of samples tested. So we're not sure how widespread what other variants are also circulating through the population. So the national response, I think this is probably similar to every other country with the different pillars involved. We had 10 pillars who were responsible for the response, of which number 6 was the infection prevention and control pillar. So this is the pillar. It was established based on a committee we already had in place, which is the National Infection Prevention and Control Committee based in our Ministry of Health. It was a multi-departmental committee, included different Ministry of Health departments, other ministries. Our ministry, it's actually now the Ministry of Public Works, is responsible for health facility buildings. Our environmental management agency was part of it. And then there were a number of partners and stakeholders from universities, professionals association, representatives of our provincial medical director. But we use that as a basis of formation of the IPC pillar and expanded it to include other partners and other organizations you can see at the bottom that we added to that. So we had extensive representation. Over 50 people used to come to the original meetings. It's gone down considerably since then, but at least we had a good foundation to start with. And I thought it'd be worth looking at the strengths that our national IPC program had at the beginning of the pandemic. We had guidelines in place. Admittedly, they were a little out of date. And we also had a national policy which defined structures in different levels of healthcare. We had this functioning national committee, and it had 3 technical working groups for infrastructure, training, surveillance, and monitoring and evaluation. We had a national Ministry of Health approved basic IPC training program that came with a facilitator's guide. So this was a basic 5-day training program in infection control. We'd also recently established a postgraduate diploma in one of our universities, and 14 graduates had just completed that program. We had an IPC coordinator and a Ministry of Health certified team of trainers in each provinces. The number, we had trained originally over 100 trainers, but there were very small numbers left at the beginning of the pandemic, but there were certainly a core in each of our provinces. We had worked at strengthening IPC in the pre-service training programs. We have, as Anna mentioned, an Infection Control Association, which is linked to ICAN. And we started working on screening programs, in this case, for healthcare workers for TB and needle stick injuries. So we had elements that helped us build our response. But these are the challenges, that few of our health facilities had full-time focal persons. The IPC programs introduced into the government health facilities were struggling with staff shortages. So often the infection control focal person had to multitask and didn't have enough time for infection control. We'd identified our primary healthcare facilities had weak IPC programs in a 2019 audit. We didn't have budgeted programs. There was shortage of PPE, inadequate training of our focal points in outbreak management and IPC. And of course, we had enormous challenges to roll out training for COVID-19. I'm sure this is common to many of you. We had updated our national guidelines, but we hadn't funds to print and circulate. So this is the objective of our pillar, obviously to limit transmission for COVID-19, but not just in health facilities, but also in communities. The pillar identified activities, so plan and budget, reference materials, capacity building, PPE supply and management, although this became the responsibility of our procurement pillar. And then obviously all the infrastructures that's required for COVID-19 patients, the isolation centers and critical care units, we were linked over into. We weren't necessarily responsible, but our input was important. And then obviously monitoring and evaluation of the program. So we put together different materials. We called on the expertise that we had, printed the national guidelines, but added an addendum of standard operating procedures based on the WHO guidelines. We produced guidelines for the community with the help of partners, and we had a separate document for PPE. As for many countries, PPE use was very controversial, and there were lots of different opinions, and the IPC pillar tried to hold the WHO guideline line, but some elements of our health community thought they needed more. So we published these guidelines, we've updated them, and we're just in the process of updating the training associated with those guidelines in line with the WHO recommendations. We developed different training modules. We used our basic IPC module as a basis for the training, but also obviously added on specific COVID-19 requirements. So we had modules for different categories of staff. We updated our national trainers. We were involved in quarantine centers, but quarantine centers were not our direct responsibility, but we assisted with the training. And we developed a 2-day integrated training for IPC and case management for clinical staff and 1 day for ancillary staff. And I'll explain in a moment. We reintroduced the basic IPC training, which was updated to include COVID-19 requirements. So those are our training modules. So this is just a brief run through of the phases. And this is what we learned from what worked and what didn't work. So we obviously started out in small steps. We had short workshops for the College of Public Health Physicians and through the Infection Control Association. We tried to use a Zoom platform to update our national IPC trainers because our programs were determined to a certain extent by the level of lockdown in place at the time. So we've just come out of a major lockdown with our phase 4. So there was a limited amount of traveling possible for our health workers. Zoom platform is difficult, but we're getting better at it. And we found it an extremely useful way of delivering information. It has its challenges, but there we are. So we circulated the presentations in our modules to our trainers and the standard operating procedures. And then we began this massive rollout of training across the country, and different pillars were involved. We initially started with an extensive 3-day IPC module and then a 1-day for the ancillary workers. So we, as you can see with the numbers at the bottom, we trained quite a large number of people. But in the second phase, we took into account that if we were taking health workers out for a 3-day training for infection control, and our colleagues in the case management pillar were also doing a 3-day training, there probably wasn't enough health workers left in the health facility to look after the patients. So this is why we developed this integrated IPC and case management training. And in the second phase, this was used by ourselves in the Infection Control Association and other partners to roll out throughout the country. We continued with input in the quarantine and isolation centers. So that was part of our responsibilities, but also the pillar was involved in updating the nurse tutors and the clinical instructors, because much of the nursing done on the wards was being done by student nurses. So it was really critical that they received training and their trainers received training. And at community level, there was extensive training of village health workers. But then we began to do assessment. Teams from the Ministry of Health went out on site support visits to the different facilities. And they found that quite often that although the health workers were trained, they weren't actually implementing so well. So they had a checklist, site support visit tool that they use. So we began to switch emphasis in our training, and this is the third phase. So it's really to support implementation of IPC programs. And this is what we found to be really critical. We were fortunate to receive funding for what we call training of IPC district mentors to support particularly the primary healthcare centers. We introduced the COVID-19 updated basic IPC course. So often IPC focal points will be appointed but have no training whatsoever. So this course was introduced, and several sessions of the basic IPC course have been held across the country, and this is an ongoing activity. We have a huge problem with staff attrition, so continuing training is important, even though it does take people away from the workplace. But to address the issue of taking people away from the workplace, we have developed a couple of our partners, ICAN being one of them. Icarus project is another project that has worked on short IPC modules for use by mentors, IPC focal points, primary healthcare centers and hospitals. And these are 1 hour lunchtime type modules, very practical, doesn't necessarily need a projector, don't have to show slides, but they have IEC materials associated with the modules that can be used for training on site. And I think that's what we have to focus on, to make sure that people like going to workshops, but coming back, they often forget what they learned. So these on-site training modules implemented by our IPC mentors and the focal points are really, I think, an important way forward. We've just introduced these maybe for about 2 or 3 months. We piloted them in our city health clinics, and the participants were enthusiastic. So we're moving that forward. We're also making now much better use of the virtual platform for IPC training. We're fortunate to be one of the partners in the ICAN ECHO agreement that uses the ECHO platform for training. So we're making good use of that for training IPC mentors, but also our own association mentors. And then much more dependence on site support visits for mentorship and monitoring IPC programs and COVID response. So these are just various tools, and this is a good thing and a slightly challenging thing. We have a number of different tools, and these can be a bit confusing for those who use them. So a risk assessment tool to evaluate implementation of programs, a similar tool used for site support visit to monitor progress. And then we have a national tool that the ministry uses to include more than one pillar, not just infection control, but case management and advocacy issues. So those have been helpful, but too many tools can cause problems. So just a couple of slides on lessons learned. So an overburdened health system can be overburdened with training. That's something we learned. And that training workshops alone are not sufficient to achieve good IPC practice. The interventions we have introduced to reduce time spent in training. So we integrated our case management and IPC modules. We have developed these short modules for use in facility-based training. And we also have introduced these provincial and district IPC mentors and hospital link persons. We put a lot more emphasis on site support visits, risk assessments, and use of the monitoring tool. And also to support the health workers more, the Ministry of Health, with the support from WHO, are really strengthening the COVID-19 screening programs. You saw our figures at the beginning for health workers, that we have a lot of health workers being infected, but we want to identify where these infections were acquired and what interventions would help in reducing them. So Anna, I'm not sure about how much, am I going over time?
You've got a few more minutes, Val. We've got some time, so you can.
Thank you. Okay, so I just wanted to say a little bit about the mentorship program because it has proved to be very useful. This is a project-driven program, but of course we're working with the project is working with the Ministry of Health and both at national and provincial level. But the program is able to support 257 primary healthcare facilities in 9 out of 10 of our provinces, supported by CDC and Resolve to Save Lives. The mentors receive training, both virtual and face-to-face, on IPC knowledge and skills to support improvement of implementation of COVID-19 IPC measures. And this program is specifically at primary healthcare facilities and some of the rural and mission hospitals. So the capacity building process includes the trainings, face-to-face and virtual, as I said. We use videos, case presentation as well, and this is supported by the ECHO program. But also we've set up WhatsApp groups, which I think have been extremely helpful. They have each province, I'm not sure if it's each province, but certainly several of the provinces have established WhatsApp groups for their IPC focal points. But also, an additional component in the training is on-site IPC skills training. It's very difficult to put across the basic skills of IPC sometimes on Zoom. So this on-site IPC skills training and learning, helping our mentors to learn how to do competency assessments, particularly in areas such as hand hygiene, correct donning and doffing procedures, environmental cleaning, but it expands to linen management and waste management as well. This is a really critical component because you have demonstrations, return demonstrations on putting on personal protective equipment, the use of tools for monitoring environmental cleaning, and then how to monitor and improve hand hygiene. This is really becoming an important component of our process, and we would like to extend it to many more facilities. And then as we're building capacity, the mentors are also conducting monthly mentorship and site support visits, and from time to time, including the provincial and district health teams, as well as our national teams. So this is an important component. It's really important to include our management, and that's what's been happening. So the combined capacity building approach has resulted in marked improvements of IPC performance ratings. We use a scoring system on our monitoring and site support visit tool rather, which allows us to score the IPC program in each facility. And we've been able to see improvements. So mentorship through site support visits have become an important component of IPC pillar support. So it's at all levels, from national, provincial, and district. And then we have another cadre, which is not new to infection control. The linked nurse is an important person in supporting the IPC focal points in the bigger health facilities. But we expanded this to include people from different departments within the hospital, because with the transmissibility of SARS-CoV-2, no department is exempt, even administration. So there have been trainings of linked persons on site at the hospitals to really equip them with more knowledge about transmission of SARS-CoV-2, but also the measures that will reduce transmission. So they are working to strengthen COVID-19 screening, triaging, and in the isolation centers that we have to give them better information. And they're there to monitor IPC practices and ensure adherence to recommended standards. So they're a very useful cadre. But there are challenges. When you have shortages of staff in particular departments, obviously it's very difficult for these linked persons to really assess, monitor, and assist in training. So this extended linked person network is still a work in process. We've had linked nurses in our central and provincial hospitals for a few years. But to bring that now to district level is a new area, and we're still working on that. So ongoing gaps. So we still have training gaps with new appointments, attrition, and new IPC focal points coming in. So our training we have to recognize that training is always ongoing. As I said, our IPC mentorship program is not nationwide, and we would like to continue. We also have infrastructure challenges, I think, as many countries do. But we have a lot of support from partners who are working on that. So the way forward, sorry, my voice is going. So we're working on IPC program strengthening activities. So it's not just training of health workers. We had a national IPC planning meeting last year for senior managers to look at the way forward and how we strengthen our program at national level and at facility level. We're reviewing our policy and we're about to embark on a pilot national HAI surveillance project. So there's still a lot to do, but I think particularly the mentorship and the linked person program are worth taking note of, because I think they will help strengthen implementation in our health facilities. But it's still important to really strengthen the program as a whole. We sometimes focus on lots of workshops and get people trained, but we need to spend more time strengthening the implementation of infection control programs within our facilities. So that's a little bit of our experience in Zimbabwe. So thank you.
Thank you very much, Prof. Val. It was great to see and hear what's been happening in Zimbabwe. I'm going to move directly over to Dr. Ronnie Bahaltungiri from Uganda. Dr. Ronnie, I hope I pronounce it correctly. It's so much easier to just say Dr. Ronnie. Dr. Ronnie is the IPC Desk Officer, Secretary of Case Management Pillar at the Ministry of Health. Dr. Ronnie is also currently a student for the IPD with ICAN. He's done his fundamentals course of 6 months last year. So over to Dr. Ronnie. Has been on this before. So Dr. Ronnie, over to you.
Thank you so very much, Anna. I request that you share from your side.
Okay, let me share for you. Okay, Okay, can you see my screen?
Yes, I can see your screen. Thank you so very much, Anna. Good afternoon, good morning, everyone on the call. As introduced, my name is Ronnie Bahatunjire, and I'm going to be taking us through the experiences of the Uganda COVID-19 pandemic response. Next slide. So we'll look at what exactly worked for us and what challenges we faced in the COVID-19 pandemic response, or what we still are experiencing, and how we've attempted to address these challenges, and what we are seeking to do to improve the long-term IPC implementation program in the country. Next slide. So looking at what the country setup of the COVID-19 pandemic response is, we have a national task force that is domiciled at the office of the Prime Minister, and this pertains over all national COVID-19 activities. And coming down to the Ministry of Health, we have the incident management system that has been set up, and with this we have several pillars, of which case management is a part. And under the case management pillar, that's where we have infection prevention and control. And this was married with WASH for this particular response because of the close relationship that there exists between IPC and WASH. And some of the activities that we've been able to achieve or undertake have been revising, adapting and disseminating the national IPC operating standard procedures. COVID-19 to us as a country occurred as a blessing in disguise because it happened in the wake of when we were winding up with the Ebola response. And much of the work that had been done or that had been put in place was in response to the Ebola epidemic. And COVID-19 came in and found us when we were still in response mode. So the systems were already in existence, despite the fact that they needed to be adapted for a particular response and suitability. So with this, we've been able to have specific infection prevention and control refresher trainings for our healthcare workers. And we've also had to conduct a particular healthcare worker, COVID-19 healthcare worker infection surveillance, as well as ensuring that the facilities have ease of access to water and all the other quantities of the WASH elements. And the biggest challenge we've had with this was, like later on we'll see. Next slide, Anna. Looking at what worked for us, we prepared this slide in rather a congested manner. We'll be excused for this, but it was for ease of relation on how our response has been coordinated. And we looked at it from the angle of leadership and management, where we've been able to strengthen our national IPC structures through establishment of the national coordination entity at the Ministry of Health. As I've already highlighted, COVID-19 to us as a country happened as a blessing in disguise. And with this, we've been able to achieve that particular element of strengthening the national IPC coordination structure. Previously, we had IPC domiciled in the governance department, but because of what happened in the Ebola epidemic and then the COVID-19 coming in, this particular component of IPC found its home in the clinical services department, where it has been domiciled for the past 2 years. And we are now working through to make sure that we build up the national IPC structures. And with this, there has been lots of work that have been done. And one of them has been rationalizing the national IPC structures, partners, particularly to make sure that we improve coordination of these partners. And this has helped us minimize both resource and resource duplication, as well as activities. And in that rationalization, we've had lots of support that has come in, and we have since been able to complete our national IPC strategic framework and plan draft for which we are working on, and we're hoping that in the next few months we should have a national IPC strategic framework and plan against which we're going to be able to formulate our national IPC guidelines. We already have guidelines that are in existent, but these have since become obsolete because they were last drafted in the year 2013. And when you look at the current implementation of IPC, they do not speak to all the concerns that would be consistent with the current practices of IPC. So that's the reason why we are seeking to revise them, and we are in a high gear to make sure that we have this in place and improve our operations. And looking at COVID-19 specifically, under leadership, we've been able to have established a national IPC sub-pillar under the IPC, under the case management pillar, and this has enabled us routinely coordinate activities in the facilities and at national level to make sure that we have ease of coordination and tracking of priority issues. And with this, we've been able to prepare and quantify PPEs, and we've been able to monitor distribution of materials in the facilities, especially with WASH, and the logistics pillar has been very critical in this. So looking at the IMS system, the IPC sub-pillar has helped greatly in coordinating the distribution of these logistics and making sure that all the facilities at least have ease of access to commodities whenever they are needed. The shortfalls are notwithstanding, and the stockouts as well. Then we've also had concerted effort in triaging and isolation of suspects and cases that have been confirmed for COVID-19. And with this, we have since come up with guidance on how to manage cases and how to manage suspects. And the IPC sub-pillar particularly came up with guidance that was incorporated into the national IPC, the national guidelines for the management of COVID-19. And this is what pretends, or that provides overarching guidance to the whole entire country on how the COVID-19 pandemic response is looked at or addressed. And with this, we've been able to also standardize the IPC training materials, especially for healthcare worker capacity enhancement. And in this, we've had aspects of key IPC messages that have since been developed to make sure that we enhance the learning and implementation of IPC by the healthcare workers, as well as the general public. We had challenges of a low healthcare worker index of suspicion or risk perception for COVID-19, and this was one of the leading drivers of healthcare worker infections. But with these key messages that have since been translated into animations or video, we've been able to at least address or reach a deeper penetration of message dissemination in the healthcare worker population. Looking at facility or IPC, institutional IPC implementation, we've been able to establish district IPC focal persons, and these have been so supportive in mentorship of healthcare workers across the country. And with this, we've been able to address healthcare worker training or capacity enhancement, drawing from the fact that we had challenges of reaching the healthcare workers. So we dropped down to an aspect of mentorship, and this was mainly in the areas where we noticed surges of healthcare worker infections particularly. And we have since had a dashboard developed that is reporting on all IPC indicators, but particularly healthcare worker infections. And under home community IPC support settings, we've since had standard operating procedures developed, especially for the reopening of social facilities, schools, businesses, and any other social places. We've also had input in the training of attendants or people that attend to the points of entry, despite the fact that this was entirely under a different pillar altogether. But working together with the different pillars as a team, we've been able to have the people attending to these facilities enhanced in their capacity to address the travelers and thereby reduce their risk of exposure to COVID-19. One key element that we've had as a challenge has been healthcare worker infections, where presently we have over 3,000 healthcare workers that have since been exposed to COVID-19 with a case fatality of 6%. And as a country, we've been able to develop a healthcare worker surveillance and safety toolkit, majorly to address aspects of healthcare worker infections. And next slide, Anna. With this, we've been able to join hands with the surveillance pillar to make sure that we categorically follow up healthcare worker infections and investigate these healthcare worker infections through the incident reporting, where we seek to identify what the leading or drivers of healthcare worker infections are, and thereby instituting appropriate interventions. And this has been provided for in the electronic infection disease surveillance and response system. And we are able to follow this up routinely and monitor what exactly is going on across the country. And then we are able still to provide such IPC capacity support in the different regions where we find challenges of a high COVID-19 surge amongst healthcare workers. And this is particularly supported by partners. WHO, we've had SID Global coming through, we've had the Infectious Diseases Institute coming through, and these have helped us in training such healthcare workers that have helped us in addressing challenges of healthcare worker shortfalls, especially in those areas where we've had a high burden of healthcare worker infections. Next slide. This is an illustration of the guidelines that have since been put in place. We've since the pandemic response in March of 2020, developed the national guidelines for the management of COVID-19. And this has since been revised to the 3rd edition, which should be released anytime from now. And the picture on the right is just an illustration of the different levels at which we are looking at infection prevention and the use or the appropriate use of PPE, and we'll the different levels from level 1 to level 4, where level 1 clearly speaks to people that are working within the healthcare facility, but have minimal or no contact with patients. And then level 2 is having an aspect of exposure to patients, but with minimal or no contact at all. Then level 3 is talking about people that are working in low-level area, low-level or low-risk areas, especially in the mild to moderate disease aerosol generating procedures performed. And then level 4 is speaking to people that work in the intensive care unit and in other areas where we find aerosol generating procedures performed. Next slide, Anna. Next slide. Or maybe just before, maybe it would be pertinent to speak about the different partners that we've had that have contributed to, no, just the previous slide, Anna. No, the previous one. The previous one. Yeah. Looking at this bar down here, it speaks to the different partners that we've worked with in the COVID-19 pandemic response. No. The picture of the guidelines.
Sorry, Dr.
Another
Ronnie,
picture of the guidelines, please.
Your voice is breaking up, but let me go to there. Yes.
The next slide. The next slide. Yeah. So I was speaking to the partners that we've worked with in coming up with the guidelines and the whole entire COVID-19 pandemic response. And well, I think we're missing each other. Well, this was just an extract of the levels of PPE prescription in guidelines, especially in the infection prevention and control section on the guidance that is provided unto healthcare workers, what PPEs are prescribed at different levels of care. Well, we have level 1, level 2, level 3, and level 4. And level 1 is what we talked about already, where there is no contact with patients. And then level 2 is where there is exposure to patients, but minimal or no contact at all. Then level 3 is where we have a low risk of transmission of COVID-19, and especially in areas where there are no any aerosol generating procedures performed. And then level 4 is talking about areas that are high risk or where we find aerosol generating procedures performed. Key to note here is the use of gumboots that was prescribed, that was prescribed in this guidance, and this goes against the practice as prescribed by the infection prevention and control practitioners. But for the country-specific information, this was included particularly to buy the confidence of the healthcare workers who were declining to gain access into the COVID-19 treatment units for fear of exposure. And we all know that risk perception is something that is very helping ourselves and helping the healthcare workers continue offering appropriate care unto the patients. This was included, but it's not one of the key recommendations that you can have in managing COVID-19 patients.
Dr. Ronnie,
next slide. Can you hear me?
You are breaking up. We've just got a few minutes more. If you can wrap up for us, please. Can you hear me?
Okay. This is just an illustration of one of the. Can you hear me, Anna?
You are breaking up.
I don't know what's happening.
Yeah.
I think it's better now. I think it's better now.
All right.
Okay. Yes. So, I was just giving an illustration of one of the mentorship activities that was happening with the village health teams that have been very critical in the home-based and isolation care strategy that has helped us in decongesting the healthcare facilities and thereof managing only patients that warranted hospitalization. Next slide, Anna. Next slide. Yeah, so this is just a summary of the challenges that we've faced in the COVID-19 pandemic response, where we've had challenges with monitoring and reporting of our work in the IPC implementation domain, majorly because we did not have routine reporting structures, but this has since been addressed, and we are working on an IPC M&E framework, and with inclusion of a few indicators that are going to be routinely reported about. Then we had a poor risk perception among the healthcare workers that is still affecting us, and this has led to a high incidence of COVID-19 amongst healthcare workers, and many of them that have gotten exposed, this exposure has not happened in the facilities, but rather in the communities, because we continue being members of the community despite being healthcare workers. We've also had challenges with supplies of PPEs and any other wash commodities, just like has happened across the world. But with immense partner support, we are seeking to address this challenge as well. Then lack of adequate support in the infrastructure, especially running water, because many of the facilities were actually not having systems that were up and running. But this is still being addressed using the Health Infrastructure Department of the Ministry of Health. And in going forward, we are seeking to have a prioritization of budgeting for IPC budget allocations from the national budget allocations, and thereafter we've had to entirely depend on a partner or donor support, which is not sustainable, and many a time it is limiting. So we have lobbied the Ministry of Health to consider IPC as one of the key areas where a budget should be allocated for effective and sustainable development. And then we're looking at strengthening of the national IPC structures, both at national and subnational. And with this, we are seeking that it shall be clearly prescribed in the national IPC guidelines that we are developing, that will, and its terms of reference will speak to. Then we are engaging with institutions of higher learning to develop curricula for both in-service and pre-service, and this is a work in progress, and Makerere University College of Health Sciences, and we are hoping that in the next 6 months, at least we should have to be able to train IPC in country with a robust and sustainable national IPC and M&E plan under development with support from partners, especially MEDS. And we are also seeking to, Anna, could I have some protection?
Yes, please go on.
Yeah, so working with the Health Infrastructure Department, and that is the engineering department, we are seeking to have IPC involvement or engagement at all the infrastructure developments that are being planned for the country, to make sure that at least all the structures that are coming up, they'll be conforming to IPC provisions, and thereby IPC implementation will become a much easier and smoother endeavor to undertake with less at a later point in time. So with this, I come to the end. Thank you so much for listening to me.
Thank you, Dr. Ronnie. Thank you very much for this opportunity to see what is happening in Uganda. I'm going to move over to Emmanuel from Cameroon. I want to introduce Emmanuel. Emmanuel is a nurse by profession, and he's also the IPC lead. So Emmanuel is part of the Infection Control Society in Cameroon as well, for the Baptist Convention Center. So Emmanuel, over to you.
Thank you, Anna. Can you hear me? Can you see my screen?
I can hear you, and I can see your screen.
Thank you, everybody. Good morning, good afternoon, wherever you may be. We'll be giving you a COVID-19 reflection of the Cameroonian country perspective, since I don't directly work in the Ministry of Health, but I think I have a little information that I can share with you this morning concerning what is going on in Cameroon. We will talk, see what the objective of the Ministry of Health was, look at how we did the case management, look at some key achievements and gaps and the lessons learned, and then we see the way forward. The objective of the Ministry of Health was to kind of what you see to, excuse me, Anna. Okay, to prevent, to detect, and to respond to the threat posed by COVID-19, and also to strengthen the national IPC system that is ongoing. And IPC has not been fully absorbed into healthcare in Cameroon, except for the private sector. So far, we have had about 10,000 cases, about more than 1,800 deaths, and about 3,700 healthcare workers have been infected, and we still have 2.3 million samples being tested throughout. We have a fatality rate of 1.7, And the vaccination rates are still very low. We are still about 6,600 people. A lot of people are not yet too interested in that. How did we do this? What actions are being taken? What innovations are being done? What gap do we have? The IPC revision of guideline was based mostly on transmission-based precautions, on contact precautions to droplet precaution. That was the focus. But as we see there, the picture they demonstrate action as a bus stop at night, which they do a systematic screening before people can travel. In the domain of surveillance and case management, it was quite active case finding, and cases that were suspected were put under quarantine, and those that were diagnosed positive were either nursed in the hospital or in intensive care units, or were either nursed at home. In Cameroon, a couple of designated areas according to the health districts were identified and designated by government, both from private and public sectors, and were empowered and given the necessary resources to be able to manage these cases as the case may be, and each case was managed according to the guideline produced by the Ministry of Health. And the flyer you see there mostly in French. Cameroon is better spoken in French, and a sample of the brochures and flyers that we had here. The key interventions that we have seen in Cameroon begin with the revision and adoption of guidelines for standardized care. IPC SOPs were done, case management SOPs were done, instrument processing, environmental cleaning and disinfection, housekeeping, and all the other ones where SOPs were also revised. There was a lot of training and mentorship centrally at regional and district levels. The Ministry of Health determined most of the action to be taken, designed the curriculum centrally and disseminated to the regions. But emphasis was based on standard precaution and transmission-based precaution. So that is the focus of training and mentorship at all levels. There was a routine, systematic surveillance of healthcare workers in an attempt to see if they could slow down infections among healthcare workers. When COVID started in Cameroon, we had a very surge, a high kind of numbers of healthcare workers. We lost a couple of medics in the first few months, and that pushed the Ministry of Health to increase surveillance among healthcare workers. There was also a massive improvement in hygiene supplies, in PPE, in sanitation, and at risk public places, such as addition of sinks, alcohol dispensers, restriction of movements in buses and schools, such as the reduction of time spent in school. So in Cameroon, one of the strategies that they used was to put the school in 2 shifts. There's a morning shift in order for children to be spaced in class, and they reduced the number of people that were moving per bus, and as such, the number of transmissions reduced. The health sector in Cameroon looks something like what we are seeing. There's a national, there's a regional, there's a district, and there's a facility level. And before the facility level, there is what is referred to as health areas. So the Ministry of Health at the level of the central administration in Yaoundé, the general coordination develops the guidelines, determine the supplies, determine the training, comes out with the SOPs, and does the communication. And as such, it is sent to the region. The region does almost the same thing and passes over to the district level. Most of the operations take place at the district level. And the level of health facilities, there was a lot of triage and quarantine, the case management, healthcare worker IPC WASH guidelines were properly being implemented, and a lot of work was done at the level of the community for public awareness, hygiene promotion, and sanitation. Here we realized that the guidelines that came, some of them, where they actually met up because we have a crisis situation when the country is fragmented, and implementing those guidelines in the English section of Cameroon where there is a war had difficulties, as the non-state armed groups do not want to see anything concerning COVID, and they had to change a few things for us to succeed, such as moving with SOPs without the ministry's logos on it, for us to succeed. But the major innovations there were the introduction of IPC committees at the national, the regional, district, and facility level. There were a lot of revision of IPC and WASH guidelines. There was the recognition of IPC by healthcare stakeholders and integration into routine care. It will suffice for me to note that in Cameroon, IPC have not really been fully integrated as part of routine care at most of the public places. But when it comes to the private sector, a lot of it is being done. Now, what were the major achievements for IPC? We can say that COVID was a blessing in disguise because now IPC practitioners can talk and they will listen to them. The Ministry of Health has come out with guidelines on surveillance, on safety, on reporting, and so on. At the level of the institution where they do the implementation, they have revamped facility IPC focal points and committees, something which we have never seen. We used to sing it like a song from the private sector and nobody listened. There's a lot of development of assessment toolkits, the development of reporting system. There's a development of guidelines for waste management, environmental specimen collection and transportation, triage system guidelines and all of that. We saw a lot of involvement of the community in terms of training, developing flyers and training materials. Some were being translated into the local languages, and healthcare workers or community health workers were being trained to proceed with awareness raising, and a high level of hygiene promotion took place, particularly at risk public places such as in churches and travel agencies, in airports and seaports and in schools and other social gatherings. In terms of leadership and management, we've seen something that is gladdens our hearts. There's a lot of strengthening of the level of the national and the regional and district structures in terms of IPC. There's a systematic surveillance and daily to weekly meetings to address burning issues. There's been a massive improvement in coordination in IPC issues, dissemination of improved guidelines and other resources. There have been improvement of the national training framework and action plan, and there's been development of a lot of SOPs and posters and flyers, which is now helping IPC to move on. Therefore, what gaps are we facing? We're facing some gaps in the domain of low vaccination coverages. A lot of people are scared to be vaccinated, and warranting a lot of awareness raising, a lot of teaching. At some point, we have stock out of vaccine at some point, and there's insufficient communication at some level, and on people to know the measures they have to take at the level of the community. There is some degree of weak monitoring, especially in areas to the north where the Boko Haram is a problem, to the east where the Seleka rebels are a problem, and to the northwest and the southwest, there's weak monitoring. There's a big infrastructural challenge in the domain of designs, in the domain of isolation units, in the domain of water supply, and the domain of design of hand hygiene, washing points, and all of that. We have a lot of challenges in resources, both material, financial, and human resources, as many people are still being trained, given the fact that it has not been completely absorbed. There's a difficulty in maintaining what has been achieved in terms of those who have been trained, in terms of infrastructure, in terms of hand washing point, due to lack of these resources to sustain whatever we have pushed for this to go ahead. That's a picture of CAN. A lot of IPC measures were taken during the CAN, and that helped though we are still to measure to see how effective it was during the CAN period. The lessons we have learned is that coordination at all levels of IPC activities is key to the successful implementation of IPC practices during outbreaks. We have equally learned that the setting up of IPC committees in health institutions is a strong determinant to successful IPC WASH in healthcare facilities. We have equally learned that systematic surveillance of healthcare workers during an outbreak and a daily briefing of staff during change of shift greatly reduces nosocomial transmission of COVID-19. We have equally learned so greatly as a country that environmental cleaning, appropriate waste management is an important aspect of hospital IPC practices. And last but not the least of those lessons learned is that community awareness and hygiene promotion greatly reduces further spread of COVID-19. We are recommending that there is need to source for additional vaccines and the need to continue to raise the awareness on the importance of vaccination. We are seeing as a way forward an improvement in communication and awareness that it will help at the level of the community for the infection not to spread, and that will be a success for IPC. We are recommending further strengthening and monitoring as a system during pandemics, and we are recommending that holding regular refresher courses, reviewing and updating guidelines, and factor in all IPC improved measures into the annual budget will help in sustainability. Thank you very much for this opportunity, and over.
Thank you very much, Emmanuel. It's great to see what's happening in Cameroon. I'm going to hand over to Lizzie Sitoli, that's going to take us through the questions and answers. I see a lot of people have raised their hands. Please type your question in the Q&A box because we cannot take on the raising hands. There's only 2 at the moment. So Lizzie, over to you.
Thank you, Anna. Good afternoon, everyone, and thank you so much to the presenters for the very informative sessions on the lessons learned. And I believe that all of us on this call have taken in 1 or 2 things in which we can also get to implement or adapt or adopt to our relevant country context. At this point, I'd like to also welcome back the presenters and also part of the panel into our Q&A session for today. And our first question will be directed to Dr. Ronnie. Dr. Ronnie, it's with regards to the PPE issues on the glove use. Kindly explain to the participants on why there is the double gloving in the guidelines for level 3 and level 4. Over to you, Dr. Ronnie.
Thank you so much, Lizzie, and thank you so much, the participants. Double gloving, like the use of gumboots, as earlier highlighted, are not some of those PPEs that you prescribed for use amongst healthcare workers that are caring for patients with COVID-19. But we also took note of the fact that healthcare worker confidence in managing COVID-19 patients within the COVID-19 treatment unit was very pertinent. And this was one of those contentious issues that was raised during the crafting of these guidelines, that the Director General had to take a position just for the safety of the patients, where all healthcare workers were declining to enter into the treatment units, and thereby we had to have it included just for the sake of healthcare workers gaining their confidence that they were protected. But with new information that is emerging, with new literature that is emerging, and with ongoing mentorship on safety and the different levels of PPE that can be used, and how COVID-19 is transmitted, many healthcare workers are actually gaining this knowledge that double gloving is not important. And at some point in time during the revision, we are going to have to drop it so that we can have guidelines mapped against the international guidelines, just like WHO was prescribing. Because our guidelines were not developed in isolation, but rather we were looking at the guidelines from elsewhere, what CDC was guiding, what the WHO was guiding, and what the region was doing. But for the sake of our own healthcare workers' safety and confidence, that's the reason why we had to include that clause and just to make sure that healthcare workers continued, patients continued receiving care, and healthcare workers were confident to access the treatment units. Thank you.
Thank you, Dr. Ronnie, for that clarification. I'll further extend the question also, or any of the panelists who would also want to comment. Prof. Robertson and Mr. Emmanuel from Zimbabwe and Cameroon, what have been your experiences on the double gloving? Over to you, Prof. Robertson, and then after to Mr. Emmanuel. Thank you.
I'm not sure what's happening now. As for double gloving, we would follow the same policy of not recommending double gloving, but we understand why people do it. So I'm not sure I have a good enough perspective of what's on the ground at the moment. Thanks, Lizzie.
Thank you, Prof. Over to you, Mr. Emmanuel. What has been the Cameroon experience?
Thank you, Lizzie. The issue of double gloving in Cameroon has been in some institutions, like I said earlier in my presentation, that IPC measures have not really been fully integrated. In some institutions, some people do, but the Ministry of Health has not recommended double gloving. If you see people practicing double gloving, it is at a personal level. It is not from the Ministry of Health. But what I know routinely that has been on the guidelines of some of the private institutions is double gloving has been taking place only during orthopedic surgeries. Apart from that, we don't have any other recommendation recommending double use of gloves. Over.
Thank you so much for that. And the next question, I'm going to pose it to Prof. Robertson. It was in the Q&A before, though it was partly answered by ICAN. Just for you to give us the Zimbabwean perspective. The question was on the modules that have been developed in Zimbabwe. Do you have any that cover the non-clinical staff, for example, like the laundry workers and the housekeeping staff? Over to you, Prof. Robertson.
Thank you, and thank you for the question. I think perhaps I just didn't get the answer across very clearly in my presentation. Our integrated case management and infection control module has a 2-day module and a 1-day module. The 2-day module is for clinical staff, the 1-day for ancillary staff. So we really feel it's extremely important to train all staff in a healthcare facility, in the kitchens, the general hands, the nurse aides. So the 1-day module is very good for general hands. In addition, the linked person system also caters for a wider health worker population within the health facility. So we would have an IPC focal point in the kitchen, for instance. So dealing with issues that are relevant to the kitchen staff or in CSSD. So we're bringing more people on board in terms of mounting a response. Thank you.
Thank you, Prof. Robertson, for that answer. Then also, Anna, if you could also add in some additionals on what ICAN is offering.
Thank you, Lizzie. Yes, ICAN also have a basic for non-healthcare workers. If it's we can split it up into 1 day a week. It runs over 5 days and they do a competencies, but we also do it online now. We also have one for CSSD and for laundry people as well, and even for maintenance. And we do similar that what Zimbabwe is doing, trying to break it down into smaller modules and do it more practical for what is, needed in their environment. So we take it in the groups, and then we develop the material around making sure that they are competent and that they are understanding exactly what is expected from them. So those we can tailor-made it for any of them, and this is what ICAN has been doing. Thank you.
Thank you, Prof. Robertson and Anna for that. And Anna, another question that is also directed to you. It has been asked by one of the participants. I know we'll be having a session on waste management. Would you want to tackle that now, or just give a briefing on when the session on healthcare waste management will be on, as one of the participants is interested in finding out if there have been any studies or surveys that have been done on healthcare waste management and COVID. Over to you, Anna.
Thank you, Lizzie. Yes, there's been done quite a lot, and we are going to have a session on that. If I'm not mistaken, it's in week 4. I will double check with the week, but we are going to have WHO and CDC, and also looking at a company that are doing waste, looking forward to do it waste zero. And I think Ario would be best to discuss that. But it is going to be discussed. There's been some surveys and studies done on the impact of waste since the COVID started, and what has been done to reduce our healthcare risk waste and also for our environment. So this will be discovered and discussed, extensively in one of our sessions, if I'm not mistaken, week 4. Thank you. Maybe Ario, you can also mention something on that. Thank you.
Thank you, Anna. Dr. Ario, over to you for additionals.
Yeah, okay, thank you so much. The burden of medical waste management in Africa, that will be the focus topic on the 23rd February, that is this month, 2 weeks away. So we'll be discussing the burden of medical waste management in Africa, and we'll be having experts from WHO who will be addressing how to tackle the sharps, the PPE, and the impact the medical waste has imposed on the healthcare system, especially in Africa. So then we'll be having a guest from Africa Center for Zero Waste from Zambia. Those guests will be speaking on how we can minimize the waste and the best options for healthcare workers at the moment. And we will also be having a country experience from some African countries. And the following Thursday, the French session will take place for the same topic. Over to you, Anna.
Thank you, Dr. Ario, for that. And I thank you to the presenters and also the panel. And now I'm going to hand over to Anna for the closing remarks. Anna,
Thank you.
over to you.
Thank you, Leslie. Thank you very much to the panel. Thank you for all our speakers, Prof. Val Robertson, Dr. Ronnie, and Emmanuel. Also for Africa CDC, the ICAN people that was also on the panel. Also for all the participants, thank you for joining us. And as Ario mentioned, in week 3, I've just pulled up the program, and we will send this out to all of you so that you can see all the weeks that we are going to do, which session that you can then join. And we will then discuss on the waste management. If there's anything else that you need to know or you want to ask some questions, you're always welcome to contact either ICAN or Africa CDC, and we will direct it to where we can help you. Thank you very much. And remember about the French session tomorrow, and then next week, same time, we will tackle vaccines that are here and all the hesitancy and improved knowledge about vaccinations next week. So please, we're looking forward to see all of you. Thank you very much.